Vishal Kumar Majhi, second year PG from Sri Shankaracharya Institute of Medical Science. And as you know, our faculty and expert for today is Dr. S Balasubramanian, sir. He is senior consultant, HOD, and director from Kanchi Kamakoti Child Trust Hospital, Chennai. I welcome you, sir. And second faculty for today is Dr. N S Thakur, sir. He is additional CMO and very senior consultant from Jawaharlal Nehru Hospital and Research Center. I welcome you, sir. With this, I'd like to invite Dr. Vishal Kumar Manji for his presentation. Vishal Kumar, please.
Good evening, respected seniors and all my colleagues. I'm Dr. Vishal Kumar Majhi, and I'm PGJR2 from Shankaracharya Institute of Medical Sciences. Today, I will be presenting case history of Mr. Yash Kumar Yadav, 8-year-old male child, resident of Khairagarh Road, Durg, Chhattisgarh. Informant is mother Anjani Yadav, and she is a reliable informant. Patient presented with chief complaints of abnormal movement since 9 months, multiple episodes, not responding to commands since 3 months, not able to speak since 3 months, not able to recognize mother since 3 months, not able to walk since 10 days, fever since 2 days, and loose motion since 2 days. History of presenting illness. Patient was apparently all right 9 months back. Then he started having abnormal involuntary movement, focal onset in limbs, started with hands. It was to and fro movement with uprolling of eyes and frothing from mouth for approximately 10 minutes, followed by 30 minutes of post-ictal dizziness. In gap of 4 hours, there was first 3 episodes on January, with patient took to government hospital, and there they have started valproic acid. First episode was on January 3rd, 3 times before admission in hospital. The seizure stopped on IV anti-epileptic, followed by second episode on March, and similar type of convulsion also presented in July 2024. 2 episodes. Child started having hearing loss followed by diminution of vision. Child was not focusing eye, and wandering movements of eye was observed with slurring of speech since 3 months. It was insidious in onset and progressive in nature. Hearing problems started from April 2024. Patient was taken to ENT specialist where all hearing test was normal, but gradually hearing loss worsens and patient now can't even hear loud sounds. Initially, child was scholastically normal and plays with friends, but then from April he started falling frequently, followed by walking by support of wall, and then slowly stopped walking completely 10 days before admission. Gradually worsening in studies and avoiding playing with friends, simultaneously observed by mother. Patient also laugh out loud and occasionally is hyperactive. Sometimes patient is irritable and non-cooperative. Patient is not able to walk since 9 days, which was insidious in onset and progressive in nature, associated with weakness of lower limbs since 7 days of before admission, unable to sit straight by its own, loss of bowel and bladder control with drooling of saliva and slurring of speech is associated. Before he was able to run and play all kinds of outdoor games with friends and was very social with everyone. Patient also had fever since 2 days. It was high-grade, non-documented, and continuous type, relieved on oral medication. It was associated with acute watery diarrhea 3 to 4 times a day, which subsided on its own. Negative history. There is no history of ear discharge, respiratory distress, rash, recurrent infection, increased head size, skin lesion, feeding difficulty, vomiting. There is no history of choking, unconsciousness, or traumas. Past history. Patient had 3 episodes of seizure in past 9 months, no previous admission before 9 months, and there is no history of chronic illness and was developmentally normal before 9 months from admission. Sir, am I audible, visible?
Yeah. Please go ahead.
Then
Continue.
birth history, baby was born at term, normal vaginal delivery, 3 kg, cried immediately after birth in government hospital. There was no antenatal, natal or postnatal complication. Breastfeed soon after birth. There was no history of neonatal hyperbilirubinemia, and there was no history of NICU admission. Family history, there is no history of similar complaints in family members, even in siblings and cousins, and there is no history of death in family members, no chronic illness in family. Developmental history. Presently, developmental regression started after April 2024. Before that, development was as per age. Currently, patient's development is like a gross motor, he creeps or crawl. Fine motor, he grasps object with thumb and forefinger, pokes at thing with 4 fingers, picks up palette with assistant pincer movement. And social, he say repetitive consonant sounds, but it is slurring of speech is present. Language responds to sound of name. Sits up alone with support, but falls ultimately and pulls to standing position. Still he falls, sir. Then growth history, parents observed that growth was normal, but weight gain was slow as compared to other children since 3 years of age, with weight less than expected. Nutritional history, patient takes 850 kilocalories against requirement of 1500 kilocalories at 8 years of age. Calorie deficit of 650 kilocalories is there. Protein intake is 15 grams against protein requirement 19 grams, and protein deficit is 4 grams. He belongs to lower socioeconomic status according to modified Kuppuswamy scale, and immunization has been done according to National Immunization Schedule. Last vaccination was done at 5 years of age. So summary, 8-year-old child with seizure currently unable to walk, speak, vision and hearing loss is observed with fever and diarrhea, with normal growth, with abnormal growth, sir, it is written wrongly, severely malnourished, belongs to lower socioeconomic status and poor nutritional status. There is gait abnormality having some CNS involvement. I'm suspecting it might be white matter or gray matter involvement, sir.
Excellent, Vishal. You did a very good job in giving such a detailed history. I must compliment you. You have given a very good history. I like the way you presented the details.
Thank you so much, sir.
Let us go back to the first slide of the presenting complaint. Very nice history, very long history. Yeah, go to the first. Yeah, chief complaints. Okay. Now, this is a 8-year-old child. Am I right?
Yes, yes, sir. 8-year-old child.
You have given 6 symptoms. Am I
Yes,
right?
sir. Yes, sir.
6 or I would say 7 symptoms you are given.
Yes, sir.
7 symptoms you are given. And one of the things, do you think that all the 7 symptoms need to be mentioned as chief complaints, or you would like to change it now? Because what happens, usually the person who's listening to you, whether it is an examiner or anybody, you must remember the attention span of the listener is always poor. It includes me
Yes.
also. Okay. Because after a long day today, particularly I was away most of the time, and my concentration also is not all that good. So I will lose my lose the focus if we give too many complaints. Can you improve upon it?
I think fever and loose motion can be skipped because it is for short duration and
Ah,
it can.
correct, correct. In any chronic illness which is going on for quite some time, please do not give importance to symptoms of very short duration, which have probably brought the parents to the hospital for a consultation for that. So, do you think that fever and loose motion are related to all those 5 symptoms or not related?
No, sir, it was not related.
Not related, not related. That's my advice for during presentation next time.
Yes.
Please avoid talking about fever and loose motion, which is not significant. In fact, this what you can do, though the parents may give you those symptoms as chief complaints. At the end of the examination, if you find that these 2 complaints are not related to your primary diagnosis, you can safely omit them
Yes.
and mention somewhere that they have come to the hospital because of this. That's my comment number 1. And you have given, so let us omit those 2 symptoms, and you have given 5 symptoms. And
Yes.
convulsions, 9 months, and rest of the illnesses except rest of the symptoms except not being able to walk has been for 10 days. Okay,
Yes.
these are the chief complaints. Go to the next slide. Please go to the next slide. Okay. You have said that the patient was apparently all right 9 months back,
Yes, sir.
isn't it? What do you
Yes, sir.
mean by the statement child was apparently all right?
Sir, before 9 months, child was able to do all the normal activity. He was going to school. He was good in studies. He's in class 2, and he was playing normal with the friends. So, assuming that, I have written that he was apparently all right 9 months back. After seizures, this all complaints started.
Oh, okay, okay. Now, but somewhere in the history, you had said that he is not growing well.
Yes, sir. He is not doing well since April,
No, no,
sir.
he is not growing well. You
Also
said,
growing. Yes,
you
sir.
said, wait. Let me complete my question, Vishal. See, somewhere in the history regarding development and growth, you mentioned that this fellow has not been growing well, and you also mentioned, so I don't know how you got that history, severe malnutrition from the history. You mean to say all this started only 9 months back, even the malnutrition, or it was there previously?
It was there previously, sir. Since
Then
three
how can you?
years,
Wait. If that is the case, will your statement saying that he was apparently all right hold good?
no, sir.
See, I'm like a defense lawyer destroying all the evidence the prosecutor is giving. Okay. See,
Yes,
that's
sir.
not the problem. So when you say apparently all right, you must be extremely careful. You must be extremely careful. In fact, I would have repeated even in my previous classes, you know, the WHO defines health or normalcy of health not simply absence of disease. Okay, it's also normal for that too in pediatrics. It is not simply absence of disease. It is normal growth and development, normal social life, normal schooling, normal physical activity. So if you say apparently all right, that means everything is perfect.
Yes.
Okay. So you must be careful. You must be careful. At this point of time, you could, if I were you, I would have got more history. How would you have altered? How would you have altered now that you have recognized that this child is not growing too well and has got severe malnutrition? That's what you are saying. What more information would you try to obtain and correct that statement?
Okay, sir.
And how is it important? I hope you understand my question.
Yes. Sir, if growth is affected, ultimately there will be some malnourishment, and then there will be vitamin deficiency, and ultimately development would also be affected.
Yeah. Particularly if the child, no, to me, if you had got the history that nutritionally this child was not appropriate right from early years, right from infancy, right from the toddler age group, right from early school years, it would have indicated when the onset of the entire problem had taken place. So that way, your statement is contradictory. You are saying one hand he is apparently all right, the other. Only thing you can say apparently he was neurologically maybe he was all right. I don't know. But rest of the things you to say that he was apparently instead of that you could have said that this child about 9 months back was going to school. Was it carrying out day-to-day activities normally without difficulties? Then started having whatever symptom that was there. Okay, right?
Yes.
And the second, you are describing something abnormal, involuntary movement, to and fro, up-rolling. What are they?
They are convulsions, sir.
Convulsions. You could have converted the entire paragraph into
One word.
repeated convulsions from 6 months for the last nine months. Go to the next slide. Go to the next slide. And the previous slide. So multiple seizures so far, and it is still not controlled. Am I right? Still not controlled. Am I right? In spite of medication.
Yes.
Okay, that you could have stressed. Next slide. Next slide. And then you have said, yeah, please. I like your statement that the child initially was scholastically normal. Then he started falling frequently. He started performing badly in school. Very nice. Please go to the previous slide. Previous slide once more. Yeah. And the hearing problem, you are saying that all the hearing tests are normal. How can it be normal? In which situation all hearing tests will be normal, but the child will be having hearing loss? Or parents may feel child is having. Is that possible? All hearing tests being normal, but child having hearing loss. When does it occur and whom does it occur?
No, sir. Only on April when they took to the ENT specialist, they took only once, sir. After that, they haven't took. So in April, it was, according to history, sir, they told that all the test was normal. Doctor told that there is nothing.
No. Vishal, you have not understood my question. See, in a given case, all hearing tests are normal, but the parents say child is not listening to us, child is not hearing what we speak. What is your implication? What is the implication of such a scenario? Anybody can put in the chat box, any student who is listening. What is the most common condition in which the child's hearing is completely normal, but the parents say child is not responding to my calling him by autism? Somebody has put pervasive developmental disorder.
Sir, if cortex is involved, then
No.
it might.
Let's see. I'm not saying that this is the thing. I'm saying that that's the only condition in which all the hearing tests will be normal, but the child will not be responding to the calls. Am I right? It's a sensory inattention, special sensory inattention or inattention to speech, inattention to words, spoken language. That is autism, pervasive developmental disorder. So you must be careful in saying, you could have avoided that hearing test when they said everything. It's not likely. It's not likely. Okay?
Yes.
Right? Next. 1 minute. Yeah, I like this statement. Yeah, no, please go. Scholastically, child was normal, right? Fine, right? Worsening in studies. Very good. Next slide. Will also laugh out, occasionally hyperactive, right? Sometimes irritable, non-cooperative. Agreed. Next slide. Yeah. Now, until the last 9 days, you had said something has been happening. Seizures had happened. Child is intellectually deteriorating. Behavior problems are appearing. And he is not paying attention. He is probably not hearing or not paying attention to spoken words, right?
Yes, sir.
And nothing else was happening in his neurological system other than this.
Sir, in last 3 months, the walking problem started, but since
Ah,
9 days,
last 3
total
months. Yeah,
absence.
yeah, 1 minute, 1 minute. That's what I'm catching you now. That's what I'm saying. You are now in this slide, you are saying it looks, I mean, from what you say, it looks as if everything motor-wise was perfect till 9 days, and the whole thing had started only 9 days back. Now you are saying last 3 months, which is right.
Sir, he completely stopped walking since 9 days, but since last 3 months, this all thing started, sir.
So where should you have started this walking problem business? Where should you have started?
I should have started from last 3 months, sir.
So this story is not correct. So you should have actually captured when the motor problem started. I'm sure it must have started much earlier. Am I right?
Yes, sir. It started months earlier, sir.
Okay, right. So was this weakness? You said lower limb, upper limbs?
Upper limbs appears to be normal, sir.
Appears to be normal means in what
According to
history did you
history, he
identify?
was able to feed himself. He
More
was
importantly, in a school-going child, what question would you have asked about use of upper limbs?
a problem in
Anybody put in the chat
writing,
box? Huh?
and
Problem in next, more important than writing for day-to-day living.
sir, eating.
You should have elicited that history.
Yes.
You mean to say upper limbs are completely normal, only lower limbs are involved?
No, sir. Lower limbs are involved more seriously as compared to upper limbs.
Now, upper limb, what happened to his upper limbs?
His upper limbs now he cannot. Matlab, I don't know whether it is because of vision loss, but he's not able to eat. He's
He's
not
not
able
able to
to
feed.
write.
That you may, but okay. But the parents would have definitely noticed any weakness in the upper limbs, fingers, etc.
No, sir. He catches things, whichever things he have, he
Okay.
catches it very, very firmly, and less likely they have given history like there was no proper. Matlab, he even tries to hold something and tries to stand, but he unable to stand, sir.
Okay. Now you have said that lower limb started. I mean, it all started with weakness of lower limb first, then involved the bowel and bladder, then involved the speech and also oropharyngeal musculature. Is it an ascending paralysis or an ascending weakness?
Uh, no, sir.
Why
This
is that
all.
important? Why is that history important? Whether it's ascending or descending? Because that would give you a clue, man. See, if it is an ascending weakness, the entire gamut of differential diagnosis is different than when there is a descending paralysis.
Yes, sir.
Okay, right. Okay, next slide. Yeah, 1 minute only. Please go back to previous slide. At no point of time you mentioned anything about the tone of the child from the history. Is it important or not important?
Yes, sir. It is important.
What way it's important?
Sir, if it is hypertonia, then it is more
Ah,
likely
yeah. Is it the child hypertonic or hypotonic?
hypertonic. Sir,
Hmm?
this child was hypertonic, sir.
Hypertonic. You should have mentioned that. You should have mentioned that.
Yes.
Hypertonic, indicating that it's probably an upper motor neuron lesion. Okay, please go to the next slide. Yeah, a fever. I think this is okay. Irrelevant. Go to the next slide. Yeah, one suggestion, Vishal. don't use the term negative history. Please go to the next slide. There is no such thing as negative history.
Yes, sir.
It's a slang. You should simply address all this as part of history and not use the term negative history. There is no such thing as negative
Yes.
history. Okay, though you have mentioned several things. Okay, next slide. Next slide. Past history. 1 minute on past history. So now you have already said seizures in the last 9 months, and you are again repeating the same as past history. It's wrong. So your
Yes, sir.
present history itself is 9 months. So that I think is not
Yes.
needed. Okay, next slide. Birth history, uneventful. Next slide. Family history, any consanguinity?
No non-consanguineous
That's very
marriage.
important. Anything like that. Consanguinity is important, and the slightest doubt of a genetic disorder, what should you have done? Pedigree
Sir.
chart also you should have drawn. Pedigree chart.
Yes, sir. Pedigree.
Okay. Pedigree chart, at least. Next. Next. Okay. Developmental regression started. I'm afraid that's not a very correct term to use in the history. Now, let me ask you, that makes me ask you a question, very simple question, which I ask often. What do you mean by the term neuroregression? When do you use the term neuroregression? What are the criteria to say a child has got neuroregression? And finally, does this child have neuroregression? Sorry, Vishal, I have to ask you questions.
Yes, sir. No problem.
But there's nobody
Sir,
else to support you. There's nobody else to support you unless there are some friends willing to support you and come on video and answer.
Sir, if a patient
I hope
have
you
all,
got my question. You have used the term developmental regression.
yes,
My question to you is, it's developmental regression, it's neuroregression.
yes, sir.
Okay, neuroregression, when do you use that label of neuroregression from the history?
Sir, if patient have already gained a developmental milestone, and then if it is disappearing or if it is going slowly backwards, then we call it as neuroregression, sir.
Okay, I will give you a case scenario.
Okay,
Okay,
sir.
right?
Yes, sir.
The child is hit by a car in a road traffic accident,
Yes,
becomes
sir.
comatose, loses all the milestones. Do you call it neuroregression? Because as per the criteria you mentioned, it's neuroregression. Is it right?
No, sir. It should be progressive, sir.
It should be no. The child is progressing. Child walked into the hospital, then became comatose, became a quadriplegic.
Sir, it should be progressive as well as pathologically. Matlab, it should be not sudden if it is going insidiously.
So any sudden regression, you don't call it as neuroregression, is it? Okay. One more scenario I'm giving. Child develops TB meningitis. I'm sure you would have seen cases. The ward.
Yes, sir.
Child develops quadriplegia, loses milestones, doesn't recover at all, becomes a spastic child at 3 years or 4 years old. By definition, you call it neuroregression?
Sir, I'm not sure about this.
Not sure. Good. Okay, I'm happy. I mean, I appreciate Vishal. I appreciate your honesty. Good. In fact, that's exactly why I asked this question. Before you label anybody as having neuroregression, but I remember this as 3 criteria. Number 1 criteria, first criteria is that there should be a history of normalcy in development before the process of regression started. For example, this child, in the developmental history, you said that everything is lost. before that, you should have clearly said that everything was perfect. You must have some period of normalcy in development, and that is a criteria number one. Criteria number two, there will be a progressive loss of acquired milestones, initially starting as arrest of development, later causing progressive loss of acquired milestones. That is criteria number two. Third, all this should be there for a minimum period of 3 months. And fourth criteria, it's not a fourth criteria, previous or underlying infection, cerebrovascular accident or stroke, autism spectrum disorders, head injury, submersion injury or near drowning, all these are excluded. You now are very clear?
Yes, sir.
So these criteria should be there before you label as any child is having neuro
Regression.
regression. Now let me ask you, does this child have neuro regression? Yes or no?
Yes, sir. This child is having.
Absolutely, absolutely, absolutely. Right?
Yes, sir. Before this, the patient was having this
Fulfills the
development.
criteria. Fulfills the criteria. Okay, fulfills the criteria. Right?
Yes,
Next
sir.
one. Next one. Please go to the next slide. Yeah, again, growth. Here, most students present details about developmental history. They forget the importance of growth history. I'm glad that you mentioned. Here, you should have mentioned a few things. Of course, you had mentioned that the head size was not high somewhere else. But you should mention in the growth, you should talk about the weight, talk about the height, talk about the head size, and also about the teeth. Right?
Yes, sir.
Next slide. Nutritional history. Here, in the nutritional history, in a child with neuroregression, what important nutritional history you should ask? Child with neuroregression, what's the relevance of nutritional history?
Sir, in nutritional history, the sources of vitamin B12 or vitamin D, we should ask multivitamins,
Micronutrients,
micronutrients,
very,
and
very
macros.
important, because you must remember neuroregression, like presentation, or even true neuroregression, can occur in quite a few nutritional disorders. Typical examples being your pernicious anemia or megaloblastic anemia, even iron deficiency anemia. Iron deficiency anemia. You must remember, iron is a cofactor for many of the enzymes which are neurotransmitters, including MAO and so many other enzymes. Okay. Iron deficiency can cause attention deficit hyperactive disorder, can behave like neuroregression. The moment you start giving iron, the first improvement you see will be the behavioral improvement in the child. Okay. Cytochrome enzymes will be replaced very fast before even anemia gets corrected. Even before the hemoglobin goes up, the child's attention span will improve.
Yes.
Right? And you must also remember few other nutritional disorders, including, pellagra, other B complex deficiencies, severe malnutrition, can all behave like neuroregression. We all know the famous kwashiorkor, which causes so much of peevishness. It will look like a neuroregression, severe kwashiorkor, though we don't see it nowadays. Okay?
Yes, sir.
Right. Next one. Next slide. Socioeconomic, next slide. So, in summary, what are the problems that you identified? You identified that this child has got probably a neuroregression. Okay. And this neuroregression has been progressively happening over the last 9 months. And of course, you are not very clear when the nutritional problem started, but you are saying that there is a malnutrition also. And you have said neuroregression. If it is neuroregression, the differential diagnosis is very, very wide, very, very wide. Okay. Let me request my colleague, Dr. Thakur, to take it forward from here. Professor Thakur, please add to the discussion on history before we move to the physical findings. Professor Thakur, please. Sir?
Dr. Vishal,
Yes, sir.
have you
Yes,
asked
sir.
for any infectious disease, chronic infectious disease?
Yes, sir.
Have you asked for infections like measles, etc.?
Yes, sir. I have asked, suspecting that I have asked a history of measles. There was no history of any rash or in past history measles. Sir, SSP, it can be happened. So I have asked for that.
And in other treatable cause for neuroregression syndrome?
Sir, I have also asked because they haven't told in history, but it was observed one marker, neurocutaneous marker on the face. It was
Yeah.
navius, sir, on the right side of face. So I have asked for that. So neurocutaneous syndrome, I have that for neurocutaneous syndrome. I have asked history for that, but they have not told. They have told that marker, that patch is since birth. Then, sir, because it was more towards white matter, gray matter lesions, so I have asked accordingly the history, sir.
Yes.
And, in
Okay,
gray matter, I have tried to distinguish many things between like other differential I also made is NCL, sir, neuronal choroid. This kind of things I have asked.
Right. Okay. Okay, go ahead.
Please go ahead.
So then anthropometry, height is 123 centimeter, expected was 127. It is between -2 to -3 standard deviation. Weight is 18 kg, expected weight is 25 kg, and it is below -3 standard deviation, severely malnourished. Head circumference is 50 centimeter, and BMI is 11.9 kg per meter square, against expected of 15.8. And it is below -3 standard deviations.
Vishal, is this the way you start the general examination with anthropometry? Is it customary? Is it right to start with the anthropometry first in general examination?
No, sir. I think general examination, I will start from here, sir.
Okay, first, I think in the examination, for your examination purpose, you should know how to follow a traditional order of presentation, and never start with anthropometry or heart rate or vitals.
Yes, sir.
Most important beginning statement for general examination will be your first impressions when you have a close look at the child for the first time. And in fact, even general exam, you put position, super. Don't start like that. Pediatricians always, we have strong vision. We always take clues by simply looking at the child, and one close look at the child will give you diagnostic clues very, very easily, very, very easily. So always you start the opening. I mean, you start your opening statement in an appropriate manner by describing what you see when you see the child.
Yes.
Okay, make it a good habit. I'm
Yes.
sure Dr. Thakur would agree. Sir?
Yes, sir.
Yeah.
Yes, sir.
Go ahead.
So I will try to correct myself. On general condition of the patient, patient was like when I saw the patient was giving starey look, and he was conscious or disoriented to time, place, and person, and sometimes occasionally he was irritable and non-cooperative. Patient is examined in supine position, and his heart rate was 94 beats per minute, regular, normal volumic, no abnormal characters, sir. No radial radiofemoral delay, and vessel wall thickening was not present, normal, sir. The respiratory rate was 23 breaths per minute, and it was normal pattern, sir. Abdominal thoracic and thoracoabdominal, and SpO2 was 96% on room air, sir. BP was 116 by 76 mmHg on left arm in the supine position. Temperature was 98.6 degree Fahrenheit, and CRT was less than 3 seconds.
Even this order, I would, yeah, this is what you should start with. What is the, how does the child, whether the child is ill-looking, well-looking, well-nourished, obese, undernourished, wasted, conscious, oriented, etc. Before you start talking about anthropometry and other things. Okay, make it a good habit. Okay, fine.
Then
Do not use the term non-cooperative. That's not a very positive. That's not a term. You should only say the child is difficult to examine and irritable. Don't say cooperative. After all, the child is disoriented. Where is the question of cooperation in a child who's demented? I don't
Yes.
think you should use such terms, right?
Yes.
You must be careful using such terminologies. Go ahead.
Attitude. Patient used to lie down and take right decubitus position. Then posture was flexed hip, knee, elbow, and shoulder was flexed. Peripheries warm, peripheral pulses well felt, and bilateral pupils were reacting to light.
You have any photograph of the child or video of the child?
Yes.
The posture of the child?
Posture, it's not in the presentation, it's outside presentation. Should I show, sir?
You have a slide right now to show the posture of the child. That's what I'm asking you.
It's in my desktop, sir.
Okay, don't worry. Now, the reason why I asked you, go back to your previous slide. Is this child having a decerebrate or a decorticate posturing? So you're saying flexed hip, knee, elbow, shoulder, and all that. Okay, first of all, let me ask you, what is decerebrate posturing? What is decorticate posturing? What's the significance of decerebrate posturing? What's the significance of decorticate posturing?
Sir, I can't recall this. I
It's
know
okay.
I have read, but
It's okay. It's okay. I'll show you. See, if you have any child whose fists are clenched and the elbows are flexed, wrists are flexed, okay, that is decorticate posturing. Okay, the lower limb may be extended or flexed also. That is decorticate. Okay, decerebrate, the upper limbs are extended, pronated, and the thumbs are inside. This is decerebrate. Okay, a lesion, this will give you a clue to the localization of the lesion in the brain.
yes, sir.
Okay, if it is in the brain stem, what will you have? You will have decerebrate or decorticate?
So if brainstem, then decorticate.
Decorticate. If it is in the cortex, it is decorticate. Cortex is decorticate,
Cortex.
decerebrate. Okay, fine. Okay,
Yes.
give you a clue, right? Fine. That is one. So the posture is very, very important to identify the site of the lesion, if at all there is any decerebrate or decorticate positioning. I don't know. You're not showing the pictures. It doesn't matter. Go ahead. Please go ahead.
Then head to
You
toe
are saying,
exam.
1 minute. You go back to the previous slide. You're saying flexed hip, knee, elbow, and shoulder. So I assume whether it is, you're not mentioning, it's probably decorticate rather than decerebrate. Okay, fine.
Then head to toe examination, frontal bossing was present, squint in right eye present, and hyperpigmented patch present on right side of the face, approximately 4 to 5 centimeter, and it was irregular, sir, extending till nose, nasal bridge. Mask-like face was present, and blackish pigmentation of some nails was present, sir. There is no pallor, icterus, clubbing, cyanosis, edema, and lymphedema. Sir.
Go ahead.
So this is the face of the patient where frontal bossing
So
and
what is-
blackish.
I don't agree with you that there is frontal bossing. I don't think there is any frontal bossing. Sir, Thakur sir,
No, sir, not.
it doesn't look like frontal bossing at all to me.
No, there is no frontal bossing, sir, at all.
Yeah. And the hyperpigmented lesion is a nevus or what?
It's hyperpigmented. I was little bit confused about nevus, sir, but it is hyperpigmented patch, kind of blackish patch was there.
Present from birth.
From right cheekbone till nasal bridge, sir.
No, it is present from birth.
Since birth, sir.
Do you think this is related to the child's present neurological status? Yes or no? Yes or no?
If it is no, sir, I think.
No. Now let me ask you, that may know sometimes examiners, the moment you say something like this, the examiner is going to take you elsewhere for discussion. What are the common neurocutaneous markers you know of? Can you give some examples of neurocutaneous markers
Or
or phacomatosis?
in tuberous sclerosis, there might be like Ashleigh macules.
Yeah, Ashley's macule, then
Neuro,
Okay, that is one.
neurofibromatosis, we can see capillate spot.
Okay, 2. Then anybody can put in the chat box other neurocutaneous markers. Only I said 2.
Ataxia telangiectasia also we can see.
Okay, telangiectasia, ataxia telangiectasia, where you may get in the bulbar portion of the conjunctiva, outer canthus, close to outer canthus, you may see a telangiectasia. Okay, then
The nevus usually seen in
sometimes giant nevus may be seen, giant melanoma.
linear nevus syndrome is one thing which we can.
Hereditary hemorrhagic telangiectasia may also be associated with telangiectasia elsewhere. Okay.
Yes,
Then
sir.
your Sturge-Weber syndrome, hemangiomas.
Hemangiomas.
Sturge-Weber syndrome.
Sturge-Weber syndrome.
Right? And you should also include in fact, some people even include ichthyosis as one of the neurocutaneous markers. You can have, ichthyosis in Refsum syndrome or ichthyosis in Sjogren-Larsen syndrome, which is a diplegia, right? So all these are some of the neurocutaneous markers. And of course, you should not forget incontinenta pigmentae, which has various stages. 4 stages are there. Incontinenta pigmentae is also one neurocutaneous marker. Okay. Right. Sometimes giant melanocytic nevus may also be associated with neuroregression. Right? Go ahead. And xeroderma pigmentosa may be associated with photosensitivity and neuroregression. Right? Go ahead.
Then there is blackening of nails, sir. No problem. Cholionychia, developing cholionychia, sir.
What is it? Blackening of?
Blackening of nails, sir.
Okay.
It was non-shiny. Blackening of nail was present, sir.
In a child with neuroregression, there is increased hyperpigmentation. What should be your first thought?
It would be vitamin B12 deficiency, sir.
Next to vitamin D, B12 deficiency, do you think of any other condition in which there is hyperpigmentation and neuroregression? You have already said the child is losing weight, looking marasmic, and hyperpigmented. Blood pressure is low. Huh?
I cannot recognize, sir. I'm not able to remember, sir. This is.
Will you think of adrenoleukodystrophy,
Yes, sir. Adrenoleukodystrophy.
Addison's disease, along with white matter degeneration?
White matter lesions.
Right, in this child like this, that is the first diagnosis I will think of. Of course, other than B12 deficient, but B12, I don't know. Child is not looking anemic. You're not showing pictures of the mucosa. Okay. Child
Yes.
looks hyperpigmented. The first thing I will think of if there is spasticity is adrenoleukodystrophy.
Dystrophy.
One of the commonest white matter degenerative disease.
Yes.
Okay, right.
Then systemic examination, central nervous system, sir, all respiratory system, bilateral air entry was equal and chest was clear on auscultation.
Why did you start with respiratory system first? Is it correct? Professor Thakur, sir? Sir, do you agree that?
No, sir. Should be CNS examination first.
See, here is a child who has got a neuroregression. Why are you starting with CVS RS abdomen where you're not having any findings?
Yes.
Okay, go to CNS. Go.
Sir, higher mental function, patient was conscious, alert, but not oriented to time, place, and person. Incomprehensible sound he was making, and he was right-handedness. He was spontaneous eye-opening, and spontaneous turnover and movements was present, sir. Cranial nerve examination, olfactory nerve was intact.
How did you test olfactory nerve in this boy?
So pungent smell we put in front of baby, but he was like making faces and he got irritated, sir.
Okay, fine.
And mother was telling that with smell of good food, his liked food, he gets happy. So we are assuming that olfactory nerve is in there.
Go ahead.
Then optic nerve fundus examination was normal, and visual acuity and color vision was not able to perform. Oculomotor, abducent and trochlear, right eye squint is present, no nystagmus, and pupillary reflex, both direct and indirect, was present, normal. Facial nerve, drooling of saliva was present, but no asymmetry in the face was seen. Glossopharyngeal nerve, uvula was placed centrally. Spinal accessory nerve, turn his head on both the sides, and the tongue movements were normal and no fasciculation or deviation of tongue, suggestive of hypoglossal nerve is intact, sir.
Basically, cranial nerves are normal, right?
Yes, sir. All cranial nerves.
What about eighth cranial nerve? You have omitted. You didn't see.
Yes, I have omitted, but I have checked.
From seventh, you have moved on to straight away ninth. Eighth, you have conveniently omitted.
Yes, it was normal, sir. It was normal.
It is normal. But you said the parents are giving a history of hearing loss. How did you test the eighth nerve in this boy?
He was not cooperative for sir that Weber's and Rennie's test, and so.
So yeah, that's why. So you must be very careful in such instances. Okay,
Yes.
right? You should say if you make some loud noise where he's turning to the direction of the noise, small things can be done even in a child who's having so much of neuroregression. Or you can even ask the parents whether he is responding to sound and mention that to the examiner, saying that's all I could do in this boy.
Yes.
Yeah. And don't omit completely. Does he have a hearing deficit or he's His hearing problem is more to do with the developmental regression he has got.
Sir, he's not responding to loud sounds. There might be some hearing loss, as you said that
Okay.
SNHL can be.
Okay. Okay, that you can mention actually. I produce a lot of loud sounds. He is not responding, but the parents also say he is not responding to loud noises like Diwali crackers now.
Yes, sir.
Yeah. Okay. Right. Go ahead. Please go ahead.
Then motor examination, nutrition, adequate bulk of muscle on inspection and palpation. There was no wasting. Power 2 to 3 by 5 in both lower limb of all muscle group, and upper limb it was 4 by 5 bilaterally. Tone was increased and spasticity was present in all 4 limbs. Bilateral plantar extensor bilateral plantar was positive. Fanning was present. Ankle clonus was present, and knee and ankle jerk was brisk, sir.
Hmm.
Sensory examination. Patient was responding on crude
Is there
touch.
any muscle wasting?
There was no muscle wasting, sir.
Okay. Go ahead. Hmm. Go ahead.
Sensory examination, crude touch. The patient was responding to crude touch and deep pain stimulus, and he was not cooperating for other tests, sir. Cerebral examination, there was no tremors. Patient cannot walk by his own. Pendular jerk was brisk, and he was not cooperative, sir.
What do you mean by pendular jerk being brisk? What do you mean by the term pendular jerk being brisk?
So it is knee jerk, sir. Knee jerk was brisk, while.
No, it's a wrong terminology. See, the pendular knee jerk occurs in cerebellar disease.
Yes, sir.
You don't use the term pendular jerk being brisk. It's incorrect. We say
Yes.
that the knee jerk is brisk. That's all. Go
Yes,
ahead.
sir.
You
There
cannot
was-
have a combination of pendular knee jerk and a brisk knee jerk. Right? Fine.
Yes. Meningeal signs were negative, and there was no tics, tremors, or there was ankle clonus, sir. Skull and spine was normal on palpation and inspection and health.
One minute. It is wrong to bring in ankle clonus in the movement disorder.
Yes, sir. By
Not
mistake,
an
it
involuntary
happened.
movement. Ankle clonus is not an involuntary movement. It is a reflex.
Yes, sir.
Right, fine.
Then there was no autonomic changes.
Hmm.
That's
Bowel and
all.
bladder. 1 minute. Bowel and bladder.
Bowel and bladder habits are a patient is not telling while passing stool.
Okay. When in a child who has got spasticity of all 4 limbs, which other reflex should have been elicited? Similar to plantar response, some other reflex I would have elicited in this child. It would have been very useful for me for diagnosis of the site of the lesion. Which reflex? Anybody can put in the chat box? Students,
Sir,
please.
is it related to bowel and bladder, sir?
No, I am not giving more clues. I am saying
So
similar to
we
plantar response.
must see
Similar
cremasteric.
to plantar response, some other reflex I would have elicited to localize the lesion.
Sir, anal reflex or cremasteric reflex we would have.
You should come. Have you heard of jaw jerk?
Jaw jerk, yes, sir.
What is the importance of jaw jerk in such cases? Hmm? Okay. Brisk jaw jerk is one of the signs of pseudobulbar palsy. Any child with quadriparesis like this child, you should always elicit jaw jerk. What is the afferent and efferent for jaw jerk? What is the afferent and efferent for jaw jerk? Both are fifth nerve. Fifth nerve.
Sit now.
Okay.
Trigeminal.
Jaw
Yes, sir.
jerk will be absent in bulbar paralysis. Jaw jerk will be exaggerated in pseudobulbar paralysis. Okay.
Yes.
Any child with pseudobulbar paralysis may have difficulty in swallowing, dysphonia, regurgitation, stridor, and a brisk jaw jerk.
Yes, sir.
Okay, go ahead.
Yes. So then, the respiratory system, bilateral chest movements were equal.
All
No
the other systems are normal, isn't it?
normal.
Okay, you can omit it. Okay.
So then, in investigations.
What other examination you should have performed in this child who has got neuroregression? Will you have you tried eliciting release reflexes or primitive reflexes?
No, sir, I didn't do, sir. Primitive reflex, I
Are they
didn't.
important in such children with neuroregression?
Yes,
Yes.
sir, it is important.
Yes. Palmar mental. Okay. Right? Rooting, sucking,
Yes,
right? Glabellar tap should have been elicited.
yes, sir.
Okay, go ahead. Now, don't go to investigation. Don't go to investigation. Sir, Professor Thakur, sir, I will ask Vishal to sum up the case and give a diagnosis. You please discuss before I come in again. Professor Thakur, sir, please. Yes, Vishal, give a summary of the case before you go to investigate.
Sir, 8-year-old male patient came with history of seizure disorder since 9 seizures with convulsions since 9 months, 3 episodes with vision loss, hearing loss, and speech decreased slurring of speech. It was since 3 months and unable to walk started since 3 months with complete absent walking since 9 to 10 days, and there is growth is normal, but developmentally patient is approximately 7 to 8 months of developmental age, and then patient have various the general examination was normal, but patient is severely malnourished, and patient is having nevus in the face with sterile look, um, probably because of vision diminution of vision with hypertonic gesture and decerebrate posture, and so patient is having ankle clonus with normal rest other CNS examination. Most probably, sir, gray matter and white matter might be involved, and the most probable diagnosis we think of is adrenoleukodystrophy, as skin changes we have seen, hyperpigmentation. That's all, sir.
Professor Thakur, sir? I think he's not there. Okay, fine. Now, 2 or 3 things. In this child, if I were to sum up the history and physical findings, the most significant findings are: one, there is a neuro regression. Okay. Second, there is a disturbance in the growth of the child in the form of wasting and weight loss. In fact, Dr. Vishal, you should have elicited a history of weight loss in this child? Was
Yes,
it?
sir. I did. There was no weight loss, but the weight gain
He
was
has
very
always
slow.
been thin. He has always been thin. Okay. Now, third thing is, when did the hyperpigmentation start for this child?
They have seen from 3 years, sir.
3
Actually,
years. Okay.
the
Okay.
child
And
is
one important clue to Addison's disease causing hyperpigmentation is pigmentation at the site of scars. For example, you should look at the BCG scar. You should ask the parents whether there is any scar in this child's body. Most of the scars will show hyperpigmentation. That's a very important clue.
yes.
And mucosal hyperpigmentation, was it there in this child?
No, sir. No mucosal hyperpigmentation. Only skin, sir. Cutaneous.
Okay. Then, okay. A child who has a low BMI, in fact, I wouldn't use the term severe malnutrition in a child who's 8-year-old. Above 5 years, you do not use the WHO criteria of severe PEM, okay, acute severe malnutrition, etc. You go by the body mass index and say whether the child is underweight.
Yes, sir.
Definitely, the BMI is 11, so it is underweight. Okay, that is it. Hyperpigmentation, underweight in a child who's failing to grow well. Okay, it may be Addison's disease, adrenocortical insufficiency. Of course, you have to think beyond adrenocortical insufficiency because there are other conditions which can cause hyperpigmentation, which includes hypothyroidism, hyperthyroidism, right? Drugs,
Yes.
okay, metabolic disorders, photosensitivity, etc. Right? That is one. Second is a neurological problem of neuroregression. Now, at this point of time, I'm going to ask you, Vishal, if this is neuroregression, do you think this child has got a gray matter disease or a white matter disease?
Sir, the symptoms like vision loss and hearing loss, this all are suggestive of white matter disease. But because he has scholastic regression also, and with behavioral changes, sometimes he get irritable. So I think it is more kind of mixed picture. The gray matter is also getting involved somehow, maybe.
Okay.
Demyelin.
What do you mean by the term gray matter? What do you mean by the term white matter?
So it is the area of
Can
brain.
anybody put in the chat box what do you mean by the term gray matter? What do you mean by the term white matter? Anybody, please? Very simple. Nowadays, we have mobile phones, right? How do we get signals? It originates from the towers, then gets distributed to the cable. The towers are gray matter, the cables are
White
white
matter.
matter. That's the best way to remember. The neurons are the gray matter. The myelin and the sheath and the fibers are all white matter. But under the microscope, they all look gray and white. That's why they use the term gray matter and white matter. Strictly speaking, there is no neuroregression in which there is exclusive gray matter involvement and exclusive white matter involvement. Any disease with gray matter involvement may also have some degree of white matter involvement, and any disease with white matter degeneration may also have some degree of gray matter involvement. Predominant involvement only we are talking about. Okay. And as a pediatrician, you must be conversant with the ways to differentiate gray matter degeneration and white matter degeneration. It's not very difficult to remember. It's not difficult to remember. It's very easy to remember. One by one, if you put a tabular column, You can easily clarify. Number one, in gray matter degenerative disease, dementia, intellectual deterioration, psychological disturbance, the psychosis like presentation, they are all very frequent. Two, in gray matter degenerative disease, seizures are more common. Three, in gray matter degenerative disease, pigmentary changes in the retina, retinitis pigmentosa, is more common than optic atrophy. Whereas in white matter degenerative disease, you don't get dementia, you don't get seizures early, you don't get retinitis pigmentosa, you get only optic atrophy. In fact, that is white matter degenerative disease. Right? Seizures are infrequent in white matter degenerative disease. Next is you have spasticity. Spasticity is more of white matter disease. Peripheral neuropathy, more of white matter degenerative disease. Ataxia, cerebellar ataxia, more of white matter degenerative disease. On the other hand, if it's a gray matter degenerative disease, yes, spasticity may occur, right? You don't get any sensory disturbance in gray matter degenerative. You may get sensory disturbance in white matter degenerative disease, right? And if you do a CSF analysis, if the proteins are elevated, it could mean more of a white matter degenerative disease than a gray matter degenerative disease, right? In general, anybody with a gray matter degenerative disease is more likely to have microcephaly. So if you have microcephaly, it's more likely to be a gray matter degenerative disease. On the other hand, if you have macrocephaly, more likely to be your white matter degenerative disease. Right? These are all some of the findings which will help you differentiate gray and white matter degenerative disease.
Yes.
Right? In this child who's got so much of intellectual deterioration, okay, involvement of special senses of hearing and vision, seizures, along with spasticity, this is more likely to be a
Gray matters.
gray matter. But mind you, you have Addison-like presentation. Okay, this could also be a white matter degenerative disease. Of course, now modern neurologists don't give much importance to differentiating between white and gray matter degenerative disease. There is so much of genetics which has come into neurology for diagnosis that they hardly talk about gray versus white in such cases. Okay?
Yes.
Right. Sir, Professor Thakur, sir, have you joined back? Kishore, is he there? Okay, I don't think he is there. Okay. Now, with this in the background, the other things that you must remember, there are some diseases which may mimic a neurodegenerative disorder. The most common example being cerebral palsy itself. Cerebral palsy itself. You'll be surprised, sometimes children with cerebral palsy may behave as if they are having degenerative disease. In the following situations, for example, one, a mother who's psychologically depressed because of the child having cerebral palsy will always tell you child is worsening. And you'll start thinking of degenerative disease. 1. 2. Child with cerebral palsy who develops multiple orthopedic deformities may appear to worsen. That may look like a degenerative disease. 3. Child with cerebral palsy may also have comorbid hydrocephalus. That may be responsible for neurological iteration. You may think that there is neurodegeneration. 4. Child with cerebral palsy who develops incidental metabolic problem like hypoglycemia, hyponatremia, or infection may behave like a neurodegenerative disease. Last but not the least, uncontrolled seizures in a child with cerebral palsy may make the child look like, behave like having a neurodegenerative diseases. So these are the situations in which even a straightforward case of cerebral palsy may look like a neurodegenerative disease. The other important point that you must remember is that when you say neuroregression is there, it is not synonymous with neurodegenerative disease, right? The reason being, there are a few conditions, including even psychiatric disturbances, childhood psychosis. When there is progression, you may start thinking it is neuroregression due to a neurodegenerative disease. It may not be. It may not be. It may simply be a psychiatric problem. The other 3 groups which have to be considered in the differential diagnosis of neurodegenerative diseases are, one is the nutritional group I already mentioned. Second is an endocrine group, both hypo and hyperthyroidism. Third is a metabolic group, right? A child with an inborn error of metabolism with organic acidemia may behave like a neurodegenerative diseases. On the other hand, your core neuroregression is due to white matter or gray matter degenerative disease. And nowadays, there is so much advancement in genetics, you are able to identify all of them with genetic testing and offer even enzyme replacement therapy. Depending on the age at which the neurodegenerative disease starts appearing, depending on the presence of organomegaly, hepatosplenomegaly or splenomegaly or hepatomegaly, depending on other clinical features, we should try to arrive at a diagnosis. Okay? Yes, Vishal, how did you investigate this child?
Sir, we have done CBC in which we have tried
That
to.
Dr. Thakur, you want to ask anything, sir? I saw him joining back. Dr. Thakur, please. He's not there. Please go ahead.
We have done CBC, sir, in which we have tried to find out nutritional. So we have there was no nutritional. CBC was hemoglobin was 12, sir, and WBC count is also within our normal limit, so no infectious thing. MCV is slightly less, sir, so we might think that there is some nutritional deficiency, sir. And then platelet count is also within normal limit, so infection and sepsis is not the issue here. And then we have also done calcium, magnesium, vitamin B12 and vitamin D3. Vitamin D is in borderline, sir, and rest other things are in normal. We have
Why did you do vitamin D? It's a waste of money if you ask me. Okay? Vitamin D has got nothing to do with the neuroregression. Right? I don't think one should be wasting money unless there is alteration in calcium or alkaline phosphorus or phosphorus.
Yes, sir.
Right, please go ahead.
And thyroid also the thyroid function test was normal, sir. Then a serum electrolyte was also normal. Initially, when patient admitted, we thought of some encephalopathy, sir. And
The other important group of disorders, other than nutritional, metabolic, disorders is toxidromes, lead poisoning, arsenic poisoning, heavy metal
Yes.
poisoning, iron overload, right?
Yes.
Copper overload can all resemble neurodegenerative disease, right?
Yes.
Good.
Yes.
Because good history will give you the diagnosis. Go ahead.
Then LFT, RFT we did, and it was within normal limits, sir. And CRP was slightly.
First, you have rightly said LFT, mainly because, Wilson's disease is one treatable genetic disorder, a neurodegenerative disease or a neurometabolic disorder, which can be easily diagnosed if you look at the eyes properly. A KF ring will give you the diagnosis.
KF ring for Wilson's disease, sir.
In fact, you must remember, as pediatricians, there are a few neurological disorders where the school teacher picks up the disease symptoms very fast, very early. One is Wilson's. She will find that the boy who's otherwise well, who has been a good student, suddenly has started writing badly, has started failing. Second is Korea. A teacher will identify that the handwriting is becoming bad. Third is SSP, subacute sclerosing panencephalitis. These three diseases are often picked up by school teachers, and then only the parents come to the pediatricians.
Yes.
Okay, fine. Go ahead.
Then, sir, this is the MRI of child, in which we can see the lower segment of the.
Did you do this thing, cortisol level? In this child, I would have done serum cortisol fasting. Even though the electrolytes are
cortisol we
normal,
don't have, sir.
electrolytes are normal.
Electrolytes are normal. We don't have serum, matlab cortisol we don't have.
Okay,
facility.
But I would have considered it as a important investigation for this child in
Yes,
whom
sir,
I
it is.
think is
Yes, sir.
continually good. Go ahead.
Yes. Sir, in MRI, we can see that in the lower segment, we can see that there is a hyperintensity in the occipital region. And when the upper sections of MRI, we can see that it is T2 imaging, sir. And we can see that it is even going towards parietal area also, sir. Hyperintensity. It is active neurodegenerative. It is active demyelination, sir. There is, and in middle section of the MRI, we can see that hypointensity is seen in parietal region as well, sir, in T1 images.
Go ahead.
Here also, sir, in lower segment of MRI, we can see hyperintensity lesions, demyelinating lesions, sir. And in the last sections of MRI, we can see that it is fully covered, like fully parieto-occipital cortex is involving.
Anyway, I can't see the slides properly. Okay. Nor can I read the MRI properly. Sorry.
Okay, sir.
Yeah. It's okay. It's not zoomed well. Please zoom. Can you just zoom those? It's okay. Leave it. You leave it. Don't worry. Don't worry about it. Yeah.
So
what is the report? Radiologist report of MRI.
Yes, sir. It is bilateral symmetrical confluent T1 hypointense and T2 hyperintense signal abnormality involving the peri-trigonal parieto-occipital white matter with extension into subcortical U fiber and splenium and adjacent body of corpus callosum. In the cranio-caudal direction, signal abnormality is seen in corticospinal tract.
Final opinion.
X-linked adrenoleukodystrophy with active demyelination, sir.
Okay.
As you said.
Okay.
You were suspecting it by lesion hyperpigmentation, sir.
Okay. Go ahead.
So then my diagnosis is 8-year-old male child with insidious and progressive loss of motor, visual, and language and social milestone with seizure disorder, with gray matter involvement and cortical blindness, sir, with upper motor neuron sign presented with spasticity and hypertonia without hepatosplenomegaly suggestive of demyelinating disease, most probably diagnosis of adrenoleukodystrophy or Jansky-Bilsawski, sir.
Okay. What will you do to this child? How
Sir,
will you manage this child?
Sir, if we would have done cortisol level, we might have known what is the cortisol level.
First thing you should do is fasting cortisol level, okay, and confirm the adrenal insufficiency.
Yes,
Okay,
adrenal
do
sufficiency
an
and
ultrasound.
hormonal treatment we would have given if it was dearranged.
Okay. And second thing you should have done is probably an ultrasound of the abdomen to look for any abnormalities in the adrenal gland, any clues, calcification, etc.
Yes, sir.
Okay. Third is, of course, genetic testing. You can usually do
Yes.
exome sequencing for confirmation of diagnosis of adrenoleukodystrophy.
Yes, sir.
Are there any siblings?
There is one sibling, he's normal, and there is no
Even
history
if
of.
even if the parents say child is normal, you have to call the child,
Yes, sir. All child
examine
should
the
be
child, and
screened.
perhaps do a genetic testing,
Yes.
counseling. Okay. And what's the mode of inheritance of adrenoleukodystrophy?
It is X-linked, sir. It is
Yeah. All the more you have to, for genetic counseling, it's better to, if the affordability is no issue, you have to do genetic testing and find out whether anybody who is there who's carrying the gene,
yes.
and you must counsel. And you must remember the adrenal insufficiency is treatable, but you're not going to reverse the leukodystrophy by any means. What other options of treatment are there?
Sir, anti-seizure medication we must give to stop the seizures.
Yeah.
And physical therapy we can give whatever physiotherapy.
Is there any other oil which is being used as a treatment?
I think one oil named Lorenzo oil, which have some oleic acid or kind of thing.
Yeah.
It is used. I think
Okay. It may not reverse the disease. It may.
it may not reverse, but it can slower down the progression regression.
Okay. Right. Very well done, Dr. Vishal.
Thank you so much, sir.
Sorry that I had to bombard you with a lot of questions. But
Oh,
you're the only
sorry.
one.
Sorry from
You
my
are the
side, sir.
you are the only one who was there.
Yes.
Who was there to answer my questions. You did very well, and all the best to you. Which year resident are you? Second year, third year?
Second year, sir. Second year.
Second year. So you have got one more year. I'm sure you'll come out with a gold medal. All the best. Wish you all the
Thank
best. My blessings to you. Over to Kishore.
Thank you, sir. Thank you, Vishal, for your nice presentation.
Thank you, sir.
Nice case discussion. Thank you. I'd like to thank Dr. S Balasubramanian, sir, and Dr. N S Thakur, sir. Sir, you are always with us. Whenever we ask to do the program, you are always ready, sir. And thank you for your thank you, sir, for your giving your valuable time with us, sir. And thank you for enlightening us with your knowledge and thought process, sir. Thank you again, sir. Thank you all the viewers, may it be seniors, juniors, or colleague, Dr. Gyanesh Misra, Dr. Atindra Jain, and everyone. Thank you for joining us. Last but not the least, I'd like to thank Mr. Jogesh Joshi ji and his whole Juventus group for providing us this digital platform. Thank you all. And as we all know that today is very auspicious day of Dhanteras. So I wish everyone Shubh Dhanteras and Shubh Deepavali. Thank you all. Good night, sir. Good night.
Happy Diwali to all. Happy Diwali.
Thank you, sir. Thank you, sir. Thank you, sir. Okay. Good night.